Health data is the bedrock of modern medicine, and over the last 2 decades, what counts as health data has expanded dramatically. We're not just talking about test results and clinical records anymore. Today, health data includes various factors like environmental exposures, behavioral patterns, and socioeconomic background. Together, these form what researchers call biomedical big data, a whole ecosystem of information about how humans live, get sick, and heal. And when the data reflects everyone, not just the privileged few, AI can do remarkable things. Faster diagnosis, better care, less bias in clinical decision making. That's not just technically impressive, it's ethically important. Health data powers AI, but who is protecting this data? There are 4 major concerns with how health data is collected and used today. First, data quality. AI is only as good as what it learns from, and right now, the data has serious gaps. It can be biased, unverified, or simply missing, especially for marginalized groups. Training data will always carry some systemic bias, by gender, by age, by race, because the people building these systems aren't always collecting from everyone equally. And this problem doesn't start with AI, it starts much earlier. It starts with who decides what gets tracked in the first place. Take Apple's Health Kit, launched in 2014. It was built as a comprehensive health dashboard for the iPhone. It could track blood alcohol content, respiratory rate, and your daily intake of nutrients like copper, selenium, molybdenum. But if you are a female, it couldn't track your menstrual cycle. In other words, you could track your daily intake of molybdenum, but not your monthly period. And here is what that looks like when it reaches AI. Google DeepMind developed an AI model to predict acute kidney injury days before it happens. Potential life-saving, but when tested on female patients, it consistently got it wrong, across every level of severity. Why? Because females made up just 6.38% of the original training data. The model was built on US Veteran Affairs records, a database that is overwhelmingly male. And this is not even an edge case. Some groups are nearly invisible in the data entirely. LGBTQ+ individuals, ethnic minorities, and people with disabilities. When they are underrepresented in training data, AI doesn't just fail them, it fails them quietly. Second, privacy. Every time health data is shared, privacy is at risk. That risk isn't abstract. It can mean denied insurance, leaked records, or algorithms making decisions about your care without your knowledge. And for vulnerable populations, the stakes are even higher. Data disclosure can lead to discrimination or worse. Third, excess data and commercialization. Companies often collect more than they need, and that extra data doesn't just sit there. It gets repurposed, shared with governments, or even sold to private companies. Unfortunately, we've seen this happen. Singapore's COVID-19 contact tracing app, Trace Together, was built to track infections. Then the government admitted the data could be used for criminal investigations. That's called function creep, and AI makes it worse. Fourth, data appropriation. Here is the uncomfortable truth. The people who provide the data are rarely the ones who benefit from it. LMICs, low and middle income countries, are targeted for data collection, but they are often left without consent protections, without regulatory recourse, and without the products or services that their data helped build. Even frameworks like the EU's GDPR, General Data Protection Regulation, do not fully protect people outside its borders. So, we end up with a system where some people collect, some people analyze, and the others simply give. Without knowing how their data is used, without the power to say no, without a way to push back. Data is the foundation of AI in healthcare, but foundations can be built on unequal ground. And until we fix that, the promise of AI in healthcare comes at someone else's cost.